our guest speakers. Thank you, our guest speakers, for joining us. And I will let the moderators, Zilala and Danjuma, to continue.
Thank you so much. Welcome everyone to this important panel discussion. It's titled, It's Time to Act, and it is indeed the time to act to eliminate hepatitis B. Together, we gather in a shared purpose to accelerate action, strengthen partnership, and to move decisively toward a future free from the burden of viral hepatitis. It's my great honor to acknowledge the presence of our distinguished speakers, and we're also privileged to be joined by a group of national and international experts in hepatitis B, group of researchers, clinicians, policymakers, program leaders, and partners whose collective knowledge and dedication are essential to achieving elimination goals. Thank you all for being here and for the vital work you lead every day. As we begin, let's remind ourselves that hepatitis B elimination is not only possible, it's achievable within our lifetime, but it requires commitment, collaboration, and courage to act now. Once again, thank you all for joining, and I would like to introduce our first speaker, Professor John W. Ward, MD. He's a senior scientist at the U.S. Center of Disease Control and Prevention, CDC. He's assigned to the Task Force for Global Health, where he acts as a director of the Global Hepatitis Elimination. Over 13 years as a director of the CDC Division of Viral Hepatitis, Dr. Ward was responsible for viral hepatitis surveillance, prevention, and research at the national level. He led development on the recommendations for hepatitis A, hepatitis B vaccination, Hep B and Hep C testing and linkage care. Professor Ward authored the very first National Action Plan for Viral Hepatitis Prevention in the United States, and he initiated the development of the National Academic Strategies for Hep B and Hep C. He authored over 150 publications in prestigious scientific work in viral hepatitis and HIV. He served as editor of CDC Morbidity and Mortality weekly report, and he's an editor of the Silent Victories, the History of Public Health in the 20th Century, published in 2007 by the Oxford University Press. Professor Ward is a dear friend of the African continent. Welcome, and the floor is yours.
Thank you very much. It's great to be part of this panel discussion today. I greatly appreciate all of your work to advance progress in the prevention of hepatitis B and hepatitis C, and then for those that have already been infected with these chronic viral infections, the screening and the care that can link them to life-saving treatment for hepatitis B and curative treatments for hepatitis C. And I greatly appreciate the start of this panel discussion where there was an express commitment to the achievement of goals for elimination that were set forth by the World Health Organization in 2016 and updated in 2022. I prepared a few slides just to make a few key points. If someone could share those, that would be helpful. I sent those in earlier. While those are hopefully getting placed on the screen, as was mentioned, go ahead.
Sarah will share the screen now.
Okay, thank you.
Few seconds and we'll be sharing the screen. Thanks for your patience.
Okay. Yeah, while those are being placed up there, as was mentioned, About 6 years ago, we started a coalition for global hepatitis elimination at the Task Force for Global Health. The task force was started about 40 years ago by former directors of the US CDC to help um, advance progress toward the elimination of other diseases, such as neglected tropical diseases, such as visceral leishmaniasis, as was mentioned earlier, as well as other neglected tropical diseases and polio. And for that reason, I moved from the US CDC to join the task force to build on that experience with disease elimination, to see what we could do to bring together the partners needed to build the capacity to improve prevention, testing, care, and treatment for hepatitis B and hepatitis C to reach those elimination goals at the global level. And to reach those elimination goals at the global level requires national action and national commitments. And that's, including for Sudan. The WHO has set out, the goals for hepatitis elimination and the different prevention, care, and treatment interventions that are needed to reach those goals. And those include, let's see, fantastic. If you could put those, if you could put that in slideshow, that would be perfect. Next slide, please. Thank you. As I mentioned, at an invited article in the United Nations Chronicle in observance of World Hepatitis Day, it's really important for all of us to come together to recognize our roles that can build capacity for hepatitis elimination. And that's true for the civil society organizations, clinicians, academic centers, industry, and government officials. Everybody can have a key role, and it's really that team building or coalition building that's so important. And that's why I think this type of panel discussion is so important today, to recognize bringing all of those partners together, including the key role of governments. Next slide. For the Coalition for Global Hepatitis Elimination, we're working in about 42 countries with ministries of health, civil society organizations, expert clinicians, to see how we can help build that capacity. The information about all of these activities are available on our website at globalhep.org. Next slide, just give you a few examples to raise awareness of a few key opportunities. That's critically important for Africa. Number one is improving vaccination for newborns to prevent mother-to-child transmission. Right now, 2 out of every 3 new chronic hepatitis B infections are among children in Africa because of low vaccination coverage. In Sudan, the prevalence of hepatitis B among children less than 5 years of age is almost 3 times higher than for children in other parts of the world. Only about 1 in 5 newborns in Africa are receiving that hepatitis B vaccination within 24 hours of life that can prevent mother-to-child transmission. And Sudan does not yet have a policy for routine hepatitis B vaccination of newborns, and that would be very, very helpful in protecting children and future generations from hepatitis B in Sudan and all of Africa. There is Gavi support to help countries implement hepatitis B birth dose vaccination. To my knowledge, Sudan has not yet applied for that support from Gavi, and I encourage them, the government, to do so. Next slide, please. Just click one more time. Thank you. And one more time, maybe. Just to say, the other critical opportunity is screening of the blood supply to prevent both hepatitis B and hepatitis C. In this report from WHO, you can see of 43 countries in Africa, only about 33 are screening donated blood for hepatitis B surface antigen. I am aware in Sudan of starting the National Transfusion Service, which is a great step forward to improve donor recruitment so that they can be totally voluntary, as well as improving screening to interrupt this mode of transmission that's very efficient in transmitting bloodborne viruses, and that there are low-cost tests to prevent. So continued improvements in screening of donated blood to prevent transmission in healthcare. Next slide. Thirdly, just really want to call out the large burden of hepatitis B. That's the cause of most liver disease in Africa is hepatitis B infection. The low percentage of people who have been diagnosed, only about 14 to 16% of people with hepatitis B are diagnosed in the Sudan. Only about 1 in 10 are receiving treatments. WHO has updated their guidelines to simplify treatment with very low cost, once a day medications. And the coalition this year has started a Center for Operational Research on Hepatitis B to help countries tailor models of care that fit their health system to make these low cost, effective treatments available. We look forward to seeing how we can assist Sudan in that effort. Next slide. All of this, this is critically important because liver cancer is a major cause of deaths in Africa caused by hepatitis B, and that includes the Sudan, where liver cancer is the second leading cause of cancer deaths in the country. Hepatitis B vaccination, screening, and treatment will help reduce those deaths. Next slide. The other effort I wanted to bring to your attention, in 2022, the coalition, in collaboration with Egypt and 12 other countries, started the UN Group of Friends to eliminate hepatitis. Within the United Nations, this is a way that member states come together on issues of common concern. This was a first one to raise global solidarity to advance progress toward goals for hepatitis B and hepatitis C. Next slide, please. This is in Africa. The African Union has been a very strong partner with the coalition in growing the UN Group of Friends to eliminate hepatitis, building off of the Cairo Declaration of the African Union, which was released in February of 2020, calling for member states of the African Union to do more to prevent, diagnose, and care for hepatitis B and hepatitis C. And they see this global coalition at the UN very much helpful in responding to this declaration. And we fully appreciate their partnership. Next slide. So as a result, this just shows you the number of African countries participating in the UN Group of Friends, starting with its launch in 2022 on the left, to the about 26 African Union member states in 2025, with Egypt and Uganda being co-chairs of the Group of Friends, and we appreciate Sudan's participation in meetings of the UN Group of Friends. Next slide. In September of this year, we had very strong participation from the African member states, as I just mentioned, including the director of the regional office of WHO in Africa, who gave very powerful remarks about his own personal experience with hepatitis B among family members and colleagues, and his commitment to hepatitis elimination. Next slide, please. I think I have a short video. See if you can click on that, please, and let's see if it will. It's a call for a global resolution of hepatitis elimination at the United Nations. I don't know if you can increase the volume of that. Basically, starting with the director of hepatitis at WHO, followed by the Deputy Minister of Health for Egypt, and now the Commissioner of the African Union, followed by the Regional Director in Asia, and the Ambassador from Health Minister from the Philippines. They're calling for a United Nations resolution on hepatitis elimination to continue to raise the profile of hepatitis elimination and why more countries need to become involved in its elimination, because it's feasible and will have impact in averting 7 million deaths around the world. Next slide. So I invite Sudan to formally join the UN Group of Friends to eliminate hepatitis. Greatly appreciate their participation, but a formal acceptance of this invitation will really promote opportunities for greater participation, at the global level in Sudan, which can help the national effort by engaging with a larger number of stakeholders. Next slide, please. So those are my remarks. I really am open to any questions or comments now, but please go to our website, sign up for our newsletter to become more familiar with what we're doing, and please contact me at any time when I can be helpful at jward@taskforce.org. Thank you again for your work, and I know that working together, we can advance progress toward elimination of hepatitis B and hepatitis C in Sudan. All the best. Thank you.
Thank you so much, Dr. Ward, for your speech and collaboration. That means a lot to our forum. Now, I will introduce my co-host, Dr. Danjuma Ada. He's a Nigerian prince and accomplished a public health expert on a mission to raise awareness about viral hepatitis. Dr. Danjuma himself is infected with hepatitis B while clinical rotations. He's a leading voice of hepatitis patients in Nigeria, and he uses this platform to advocate for most vulnerable populations across Africa. He wants to change the narrative about the hepatitis. He wants to change and raise awareness about the deadliness of the disease. Danjuma Ada is a native of Nigeria. He's married with 4 kids. He has a background of microbiology and MBH and over 15 years experience in advocating and raising awareness about viral hepatitis. Can you please tell us around the Act Now Declaration, Kigali?
Thank you, Dr. Zilal. Actually, I need to update my biography because it's no longer 4 kids, right? It's now 5 kids, beautiful 5 kids. So thank you so much. I sincerely appreciate this. And when Dr. Abdulhamid was talking and we were in Kigali, I remember I'm happy to see Rene here. And the question I asked was, what would you do as Sudan, as a country? And the meeting, so it's good to have a background to what actually was the Kigali, the Act Now Declaration. But I would say good morning, good evening, good afternoon, all colleagues, distinguished guest partners who are joining this across Sudan, across Africa, and across the global community. So the Act Now Declaration was actually adopted by the over 165 in-person members or participants at the Africa Hepatitis Summit that took place in Kigali. And it emphasized the urgency of eliminating hepatitis by 2030. I'm happy John, who has been greatly doing hepatitis work, like part of those efforts are efforts contributing towards elimination. The UN group of friends is using political will to put really governments to put more urgency in hepatitis elimination. So the conversation builds around this historic moment for our continent, the adoption of the Kigali Act now on hepatitis elimination in Africa. And it's built out across 2 or 3 frameworks, as John alluded. First, the Global Health Sector Strategy for Hepatitis Elimination, which sets ambitious target to eliminate hepatitis by 2030. And unfortunately for Africa, instead of 90% diagnosis, for hepatitis B diagnosis is less than, either 4% or thereabout. Hepatitis C is about 13. It's really appalling. Treatment is just 0.2%. And yet the goal is towards 90% diagnosis and then 80% treatment. And Africa is so lagging behind. Sudan is also a country that is so endemic with hepatitis, almost about 6 to 12%. So the ACNA declaration looks at what do we need to do as Africa towards 2030. This is 2025. It's saddening. I was diagnosed with hepatitis B in 2004. And if I had not started treatment out of pocket, I probably would have developed liver cancer by now. And many people are dying because they have not been diagnosed yet. Many people are dying because, in fact, in Africa, many people die almost at the crossroads of diagnosis. They don't even get to know until when they're about dying. So something needs to change if you want to achieve elimination by 2030, and that is to scale diagnosis, to scale treatment. So 1, about the global sector strategy, 2, around universal health coverage of leaving no one behind. So that in the remotest village of Sudan, in my village, nobody should not access care because of cost, because of distance, because of gender, because of lack of awareness. Care should go to the remotest and smallest community. And that is why we asked the leaders in Kigali, what can we do to change the narrative? And we all came up with the ACNA declaration, urging political courage and immediate action, domestic financing, strengthening primary healthcare. So this is something we all must do. I must sincerely appreciate Sudan for taking the first step after the Kigali Act now to start this meeting. How I wish every other country in Africa will borrow this and go beyond Zoom meetings about this is fantastic to now go into action. And I'm happy Dr. Abdulhamid rightly said, I asked him, what would you do? So colleagues, it's no longer time to talk. It's time to test. It's time to screen. It's time to diagnose. It's time to put more pills in the stomach of patients. And that is why this meeting is here. If people like me are not diagnosed, people will come down with liver cancer. I lost my mom to liver cancer because she was diagnosed too late. Many people, if they're not diagnosed by now, they will come down with liver cancer very shortly. So colleagues, it's time no longer for political talk, but time to act. And that is the essence of this meeting. And we hope that all the conversation in this room today will aim at saving lives somewhere, touching lives. And I'm happy John is here. How do we leverage the opportunity? I want Sudan to make use of this. How do you leverage opportunity of the UN group of friends to get more global visibility? How do you leverage opportunity of the co-hep opportunity? John is doing so much in this region to make sure that more people are tested, more people are treated, so that we go beyond talks and really into action. So colleagues and friends, the next 1.5 hours is really to talk and really to iterate for Sudan. What are you going to do in the next to scale diagnosis, to scale treatment, to scale awareness, to break down stigma and ensure that people are taken into care? That is what we want to talk about. Practical, real solutions rather than just beautiful English. So, but John has set the stage, and I hope that the next conversations will be about practicality, being pragmatic. How do you test? How do we get testing to primary healthcare centers? How do we get tenofovir and the DAAs into the belly of the patients? How do we break down stigma, gender bias, structural barriers, distance to facilities to ensure that every patient gets care? So thank you so much, colleagues. I hope that we would really take this matter up seriously. And when next we were talking to Sudan colleagues, we should be able to see more results. So, Dr. Zila, I put back the over back to you to continue with this while I also continue with this co-hosting and facilitating, moderating this session. Thank you. And
Thank you so much. This will take us to our 11 priorities for today's session. It's the practical steps, but I would like to take a minute to welcome Dr. Heitham M Ibrahim. He's the Federal Minister of Health, the Republic of Sudan. He's been serving in this position since January 2022, initially as acting minister. In his role as a health minister, he's actively involved in managing Sudan's healthcare challenges, especially during the time of war and related humanitarian crisis. Dr. Heitham has been very kind to be among us today. He has addressed many diseases outbreak during the time of war, including the cholera epidemics. He was spearheading the vaccination campaigns, coordinating the international partners to manage the spread of the disease. He frequently meets with international organizations and diplomats, including the WHO, the UN agencies, and the foreign government officials to secure support and funding for Sudan's health sector. And he has launched projects aiming at reducing neonatal deaths through the initiative like NUR project, which was distributing deworming devices in multiple healthcare facilities. Dr. Heitham has stressed the importance of re-establishing the National Medicine Supply Funds and enhancing the overall health system to ensure the continued access of excellent essential health service for the vulnerable populations in Sudan. Dr. Heitham, thank you so much for being here today, and over to you.
Okay, thank you very much, Zilal. I think you have said everything. Just I would like to commend your role and what you are doing for elimination of hepatitis in the country. Thank you very much for our staff at the directorate responsible at primary health care level or at tertiary care level. And also thank you very much for the speakers and the contributors from other countries. As you have said that we in Sudan, despite all the challenges, despite the war, despite the situation in the country, but the health workforce, we are committed to serve our people. We are committed to kick forward all the projects and the programs have started already before the war. And elimination of hepatitis is one of these, of course. Over the time, there was a good success made by primary health care in prevention, in vaccination, and also by our institutes in elimination of hepatitis and engagement of the community. I think we in the country, we are committed and here to show the highest political commitment of the government of Sudan to provide the support for elimination of hepatitis and for also ensuring the contribution of everyone in this, as we always said, health by all and health for all. Again, I would like to thank you very much. I'm enjoying the talk and the speech of our honorable guests from many countries. Thank you very much. And here again, I would like to commend your what you are doing, and thank you very much on behalf of the Sudanese population and on behalf of our healthcare workforce. And we are committed to outcome and the recommendations come out from this talk today and for the future plan, inshallah. Thank you very much, and over to you, Ziral.
Thank you so much, Dr. Heitham, for your ongoing support. Now, I would like to welcome our panelists. So we have Dr. Sara Abdullah Azhari. She's the Director of Communicable Diseases Control Directorate at the Federal Ministry of Health in Sudan. She also previously served as the Director of National Program to Control AIDS, Viral Hepatitis, and Sexually Transmitted Disease on a national level. Thank you so much for being among us today. Dr. Sara Azhari.
Thank you, Bilal, and good afternoon, everyone. Your Excellency, Dr. Heitham, our guest from international diaspora. Welcome all of you, the guests of today's webinar. It is our honor always to represent Sudan and to fight diseases, communicable disease, all of the communicable in Sudan, and to grasp any opportunity to fight those diseases and protect our population in Sudan. And actually, the efforts of the viral hepatitis, as I mentioned in the previous, our previous session last week, we started those efforts early in 2019, and it was before that by the effort from our national experts and gastroenterologists to fight the disease. I think in spite of the war and in spite of the challenges that Sudan is passing through, we could achieve some of the big interventions. And one of them is the introduction of hepatitis B, bear those the coming weeks. And also some of the, we could also grasp the opportunity and to integrate the hepatitis effort into the global funds support that is provided to Sudan through the ATM disease, which are the AIDS, TB, and malaria. And we could offer 500,000 USD for protection and providing prevention that is for high-risk population. The total budget of the viral hepatitis strategy, when we developed the strategy, it was $95 million. And it is quite huge budget, definitely, to fight the disease in a country like our context, because of the challenges that we all suffering from. And but this effort with collaboration and good coordination and grasping any opportunity to serve the people and to do an efficient and effective intervention, it will take us to a milestone toward elimination of hepatitis B. And considering Sudan is highly prevalent country with hepatitis B, it is really big, needs a big effort. It needs the collaboration of all, and definitely the support from all the international parties. And we are, as Dr. Heitham, our leader, said, that we are committed to fight viral hepatitis and to serve our people. Yes, definitely we are, as Sudanese people, we are serving our communities. Thank you, Zalal.
Over to you, Dr. Danjuma.
Okay, thank you so much, Dr. Zilal. And I would sincerely appreciate the Honorable Minister for taking out time to be on this call. And Honorable Minister, sir, thank you so much. It takes a lot. I say this as an African, and I know how busy ministers are, and then it's great that you are here. That really confirms to me, as I live with hepatitis B and I represent the millions of Africans with hepatitis B. So it tells me how committed you are, Honorable Minister, sir. And Honorable Minister, sir, permit me to start with you, if you don't mind, before we go to Dr. Abdulhamid. We have the global sector strategy for hepatitis elimination. We have the Cairo Declaration. We now have all framed around universal health coverage. And now there's no foreign aid. There's no foreign funding. Funding is going. Honorable Minister, sir, what would you do differently to ensure that more people in Sudan are diagnosed, are treated, and to avert liver cancer, and to ensure that care is taken right to the doorstep of the patients? Despite the war, it's fantastic to see the effort Sudan has made. And thank you so much. But we want to hear from you, sir. 2030 is just by the corner. What would you do differently to increase that commitment? And now that there's no foreign funding, what would you do differently, Honorable Minister, sir, to ensure that Sudan acts now towards hepatitis elimination in terms of diagnosis, in terms of treatment, and in terms of ensuring care goes right to the community. Honorable Minister, sir, thank you so much. And may I have the honor of your response, sir?
Anjoma?
Yes, I can hear you, Your Excellency.
Okay, thank you very much. Yeah, you are right. I think it is a challenging, not an easy job in competing priorities worldwide and competing priorities even in a country like Sudan. Yes, we are challenging due to the war, are challenging for even humanitarian top priorities. But in the same time, I would like to say that in Sudan, even before the war, we have in our reform of health system, one of mobilizing of domestic financing inside the support primary health care, for example. We have a project of a UHCC project continued for more than 10 years before the war, expansion of primary health care services in the country, and integrating the services in the primary health care, integrated approach. This is one approach that hepatitis B and integration of the services, of the health promotion, of the vaccination could be part of that. The second one is also EPI program in the country is known as one of the strongest program in the country, even during the war, and also the government with its partner like Gavi, for example. Gavi now is supporting the program, and government of Sudan and Minister of Finance usually they are committed to support this program and filling the deficiencies. Third, also we can make our maximum benefit of our partners. We have, you know, that the Global Fund as one of the partners, and also with UNFPA, the PMTCT programs and other programs and primary healthcare programs. I think the key words is that using the best of our at hand with our all partners in the country, in addition to better mobilization of the resources inside the country. This is one side. The other side, in one of the meetings I have discussed with Dr. Monem Tayyip and the primary healthcare director, Dr. Musab, if we put this issue that one of the top public health issues in the country that could be eliminated, that could be the intervention in this area, could have an impact that could be communicated with other related sectors in the country, like Minister of Finance and Prime Minister in the country. We would come with one of the programs that could be under the top level government in the country that support the whole range of activities, including the testing, including the vaccination, including the promotion programs. But really, this need a strong case to be put on the table of the government and to have the ability to compete with other priorities in the country. This is what I think about, but I think the room is there, the commitment is there, and also we can find a way of the program already on the ground that the government of Sudan is supporting already in the country. Thank you very much.
Thank you so much, Your Excellency. This is fantastic to hear. And I hope our colleagues and everybody on the call have heard His Excellency. And we hope that Your Excellency, pardon me to say that, you know, as a community and civil society, I hope we will have time next time to now remind Your Excellency to say, Your Excellency, this is what you said you want to do for your community and for your nation. And we hope that the patients and the people in Sudan would definitely remember this and would definitely pray for you to be able to fulfill all these wonderful promises to achieve elimination of hepatitis. And I think, Your Excellency, also, my friend here, John Ward, had also invited Sudan openly here to join the UN group of friends. So it's one of the opportunities, Your Excellency, I think might be important to take advantage of to join the global body towards the elimination of hepatitis. So thank you so much, sir. And it's really an honor. To John Ward, you want to say something to the Honorable Minister? Maybe let me give you 1 minute, John Ward.
Yeah, absolutely. Just again, thank him for attending this. Thank him for his awareness of the priority for hepatitis elimination in the Sudan. We have examples within the group of friends of how countries being on the international stage with their Minister of Foreign Affairs being involved does bring the other partners within the government, such as finance and health and foreign assistance together. And we hope that by participating in the group of friends, it can help your effort, Minister, of getting those other ministers involved in hepatitis elimination. And please, continue to prioritize a return to high coverage with infant hepatitis B vaccination in the Sudan and the launch of birth dose vaccination, so critically important for the health of children and future generations in Sudan. At the African Hepatitis Summit, we did hear good news from the Global Fund that they would continue to prioritize hepatitis B testing support, despite their challenges in fundraising. So please continue to call on the Global Fund for the assistance in testing and linkage to care and treatment. And please, Your Excellency, call on me and the coalition when we can be of assistance to you. Thank you.
Thank you so much, Dr. John. I don't know if His Excellency want to respond to that, or we should move on to the next presenter. Your Excellency, would you want to say something, or we'll move on with your kind permission?
Okay, just I would like to thank you, and thank you, John, and also thank you very much for support and commitment, and to ensure you at the end that we are sitting in the driving seat of the government of health. Currently, we are committed to these programs and public health issues related to hepatitis and elimination of the hepatitis in the country. And we would like also to ensure you that with our related other ministries, because the response is not a response of Minister of Health, it is a response of the government, it is a response of the leadership of a country, it is a response of the whole nation. For that reason, just we are driving the vehicle towards that, and to ensure that everyone is getting on the vehicle to have its role in elimination of hepatitis. Thank you very much.
Thank you, Excellency. Now, with your kind permission, I'll go on to the next speaker, Dr. Emmanuel Olad. He works with the Clinton Health Access Initiative. He's a senior associate country programs at the Clinton Health Access Initiative in Kampala, Uganda. And he has a lot of research interests, including maternal and child health and vaccine hesitancy and tackling public health challenges. And he has received recognition as a Chevening scholar and contributed to some numerous health initiatives. So, Dr. Emmanuel Olad, I think you have a slide to share. So you have 5 or 6 minutes to present, then we'll move on to the other panel. Thank you so much. Maybe the host secretariat can maybe share his slide. Dr. Zila?
Yeah, thank you so much, Dr. Danjuma, for the kind introduction. I'm trying to set up my slides, and greetings to Your Excellency, the Federal Minister of Health, and all panelists. It's a pleasure to share this panel with Professor John Ward, with Danjuma, and my own teacher, Professor Chama. I'll try to be fast to share our experience as the Clinton Health Access Initiative and lessons from supporting viral hepatitis B and C elimination efforts in Africa, in line with the 11 priority areas that were mentioned. Once again, I'm Emmanuel Olad, and I'm based out of Chai offices in Uganda. So CHA is a global health organization that's dedicated to saving lives and reducing the burden of diseases in low and middle income countries. Our vision is a world in which everyone is able to live a healthy and fulfilling life. And our mission is to save lives, improve health outcomes in low and middle income countries by enabling government and private sector to strengthen and sustain health systems. Our approach hinges on trusted relationships with governments to drive change across entire health systems through key roles in terms of addressing market barriers to key and essential commodities as a market shaper, strategic partnership with governments, industry and business, as well as communities, operational partner, and ecosystems catalyst. CHAI has a wide footprint in over 35 countries, and we have more than 20 programs, including infectious diseases such as viral hepatitis B and C, women and child health, universal health coverage, and NCDs. Majority of CHAI personnel are based within the countries where we work. The CHAI's Global Hepatitis Program aims to accelerate access to hepatitis B prevention, testing, and cure, ensuring that every diagnosis leads to treatment and no child is born with hepatitis B. Our approach as the hepatitis program at CHAI involves working closely with government because we know that government commitment and leadership is key to design, finance, and scale practical hepatitis elimination programs embedded in existing health systems. We aim to deliver simplified, decentralized care models, as I will demonstrate later, within national health systems, enable market access to affordable quality assured drugs and diagnostics, as well as vaccines, and sustain, mobilize resources and policy leadership for long-term elimination. Currently, we have work in over 10 countries in Africa and Asia, and our core countries where we are supporting include Rwanda, Nigeria, India, Cambodia, and Uganda, where I'm based. Over the last almost 10 years since the Global Hepatitis Program at CHAI first started, we have had impact in terms of having more than 32 million people screened and over 500,000 initiated on treatment. More than 90% reduction in cost of treatment, especially for DAAs, directly acting antivirus hepatitis C, as well as bringing parity to between TDF for treatment of hepatitis B and HIV treatment. We have also engaged multilateral donors such as the Global Fund for AIDS, Tuberculosis, and Malaria, Gavi, the Vaccines Alliance, to expand their policies to cover hepatitis B and C. Equally, we have supported more than 20 countries to develop and launch their national strategic plans for hepatitis. We have supported strengthening supply chain and digital health systems, as well as health workforce development. A brief highlight on 3 countries where we are working at the moment to share experience with you. So within the Africa region, a big part of our work over the last years have been supporting resource mobilization. In 2023, we developed a toolkit highlighting the changes in the Global Fund policy to accommodate more commodities for hepatitis B, especially for Hep B, PMTCT, and other key populations. And this was circulated in 15 countries within Africa, and all of them ended up including hepatitis B related requests within their funding application. Overall, Global Fund approved more than $60 million to support hepatitis commodities across these countries. We have also recently supported Hep B birth dose introduction across 3 countries, Rwanda, Uganda, and Sierra Leone, where we supported efforts to develop concrete funding proposals to Gavi. In terms of market shaping, to address the key market barriers I mentioned earlier, we have been supporting efforts around facilitating access to dual HIV and syphilis testing. Integration is part of our agenda. We know that most African countries have well-developed HIV programs, and the effort here is to strengthen the integration of hepatitis B services into these platforms. So we have facilitated access to the dual HIV and syphilis test kits, and most recently, also we are supporting strategies to introduce a triple triple test kit for the 3 diseases at mother baby care points. In terms of market access, I've mentioned that we have supported reduction in price for DAAs for hepatitis C to about $60 in Nigeria and in Rwanda. And this has contributed to greater access to health services overall. I want to if you may permit, with your permission, Dr. Danjuma, if you give me a few minutes to deep dive into our experience in Uganda. In Uganda, CHAI is supporting strength hepatitis B elimination of vertical transmission services as a core component of Uganda's triple elimination effort. Uganda has a high hepatitis B burden with about 4.1% national prevalence and significant variations across geographies and populations. In the northern region of Uganda, for example, more than 4.6% of the population is living with chronic hepatitis B. And so our support in Uganda has aimed at strengthening coordination to break vertical silos and enable integrated programming for services. Number 2 is to optimize service delivery by supporting the Ministry of Health to implement several approaches to strengthen hepatitis-related care and services. For example, in terms of policy and governance, monitoring evaluation, supply chain, supporting training and capacity building efforts, as well as evidence generation. Equally, to drive demand, to increase demand and awareness of hepatitis services nationally. And this we aim to advance on triple elimination targets for the country, but specific to hepatitis B, we hope by the end of 2026 to increase screening of pregnant women by more than 75% in the targeted districts where we support, having more than 75% of pregnant women linked to prophylaxis, as well as over 75% of newborns given hepatitis B birth dose within the first 24 hours. We have seen over the last 2 years of support to Uganda that strengthened data in Uganda has enabled us to better track our commodity status. And most recently, because of the funding cut experiences due to the US government stop work order and subsequent reduction in funding, that availability of commodities that were once supported through the HIV program has become a big challenge. From 2 different assessments that we did in June and November of this year, we observed significant stockouts for TDF3TC, which is used for hepatitis B prophylaxis in pregnant women. This data is strictly for only pregnant women. We have also seen stockouts lasting more than 3 months in several of the facilities that we visited. Hepatitis B birth dose availability is increasing in the country because of the Gavi support, but that is yet to reach national scale. We also see that few facilities have dedicated personnel to support integration of hepatitis B into the mother baby care points. And this has affected the overall performance of the hepatitis program in the region where we support. We see that if you compare Q1, that's the first quarter of this year, Q2 and Q3, we started off with about 74% of pregnant women being screened at antenatal care. That reduced slightly to around June to 72, and now to below 60%, largely due to commodity stockouts. And we also see increasing that few women are being linked to prophylaxis. I believe Professor Chama might talk about this, but a big factor to the challenges with the linkage prophylaxis has to do with access to hepatitis B viral load testing, which is centralized in Uganda. We have seen, however, a significant improvement in the number of babies being vaccinated at birth for hepatitis B. By the second quarter, about 82% of babies were vaccinated. These are live birth only, were vaccinated for hepatitis B at birth, and most of this within 24 hours of delivery. Recently, in the third quarter, we saw that this proportion increased to 97%, but we intend to undertake a data quality assessment to ascertain whether this change is true. Like I mentioned, this may not capture babies born out of facility. It only captures the picture of babies born within facilities. So our approach to Uganda looking forward aims to support several pragmatic priorities to advance hepatitis B, elimination of vertical transmission, as well as triple elimination services. One is in terms of supporting simplified care pathways. Our learning from Uganda is that the complexity to do with the hepatitis guidelines limits access to care, and adopting simplified approaches such as testing and immediately linking to prophylaxis without having to do viral load could enhance access to preventive care. Number two, like I showed in the previous slide, commodity security is crucial if we are to have adequate access to treatment. Then expanding access to molecular testing and other innovative diagnostic platforms like the triple test, optimizing care at lower level facilities. I was delighted to hear from His Excellency the Minister the efforts to integrate hepatitis B within primary healthcare system, which we believe is very crucial. And lastly, we need sustainable financing. Now, in summary, in terms of what we learned from across Africa, and in line with the theme of this webinar, we see that these four key themes are important. One is political commitment as well as financing. We have learned from Rwanda's progress that sustained investments and leadership make elimination achievable. Number two, countries in Africa advancing national hepatitis programs and are mobilizing domestic resources, but more resources will be required to push us over the cliff and achieve the elimination targets. So amidst these donor funding uncertainties, mapping resource availability and gaps is important to identify where alternative funding needs to be mobilized. I've already mentioned the need to strengthen integrated service delivery, the need to engage communities and civil society organizations to especially drive awareness, reduce stigma, and support linkage to care. Lastly, regional collaboration is important. We believe that through webinars such as this one, we can share experiences and knowledge in terms of how we can strengthen hepatitis programs across Africa. Over to you, Chair. We can discuss later on this presentation.
All right. Before I go on to ask Dr. Zilal, thank you so much, Dr. Imad. It's a fantastic opportunity to hear what the great work you supported the Ugandan government to do. And yeah, we have also Professor Ponsiano. I think maybe he might even, in his presentation, maybe add more to what really happened in Uganda. But Dr. Zilal, over to you to invite Professor Ponsiano so that his presentation follows immediately after Dr.
Thank you so much, Dr. Danjuma. I would like to introduce Professor Ponsiano Okama. He's a prominent professor of medicine and hepatology at the Makerere University College of Health Science in Kampala, Uganda. He's the founder and chief medical director of the Digestive and Liver Disease Care Center, and he's the president of the Uganda Gastroenterology Society. He served as a council member and the exams committee chair, along for the East and Central and Southern Africa College of Physicians. He's long experience in research, and he's well recognized internationally for his work in the viral hepatitis, HIV, and liver disease, as well as HCC. Thank you, Prof. Okama, to be among us today, and over to you for your remarks.
So thank you so much. I did not prepare any specific presentation. I attended the meeting last week, and we talked a little bit. And I also want to mention a few things. Dr. Olal has actually talked about already so many things that we have been doing in Uganda. And the elimination of viral hepatitis involves a number of, persons and organizations, including national, international organizations. In Uganda, we've actually made quite a bit of stride because of political commitment to do many things. We introduced the pentavalent vaccination in 2002, and we had a number of other strides, including massive adult screening and vaccination of those who are not infected and who did not receive the pentavalent vaccination from 2015 up to 2020, I should say. And then we have conducted a number of studies. Academia is very important in this kind of setting. We've worked together with the collaborators, including the CHAI group, the OLAL group, and the Ministry of Health and the academia to achieve certain things. We recently recruited 19,000 pregnant women in our studies and decided that we would run the viral load for all of them through the Ministry of Health. Those who are positive, we ran the viral load, stratify those who have infection into high viremic and low viremic mothers. The WHO still places the viral load cap at 200,000. Those who have mothers who are infected and have viral load more than 200,000, they would receive the TDF to lower the viral load up to delivery, especially if they don't qualify for treatment as those who are infected. And then those below 200,000, they're not necessarily started on this treatment, but at delivery, WHO says every baby should receive the birth dose. But we thought that the 200,000 was a little high, so we looked at 20,000 as a cap. And we got 660 mothers who were positive for hepatitis B, stratified them, and we got a number of mothers who were in the high viremic category, 84 mothers of the 660. And we started them on TDF. The ones below 20,000, we did not start them on treatment, but the babies got vaccination birth dose. And 9 months later, we screened the babies who were born to these surface antigen positive mothers, and we got 3 babies who were infected. WHO, in terms of elimination, is looking at babies born to surface antigen positive mothers to have, the countries should have at least less than 0.1% infection. But during the time we were conducting this study, we noticed that there were actually, the viral load is not very easy to attain, even at the central public health laboratories. First of all, the samples have to be taken there to the public health lab, and the results take variable times to go back to the sites where the mothers were recruited from. And so we looking at all these together, we thought it would be easier for all mothers who test positive to just be given the TDF for the period that they are pregnant, and they continue up to delivery, or even in some circumstances to the time when they receive the pentavalent vaccination, 6 weeks. And fortunately for this country, at least the Ministry of Health has taken this up with support from CHAI and others, and now we have taken it up that mothers who test positive for hepatitis B should should be given TDF, and especially if they are not if they don't qualify for the treatment, they should just be given this medicine to prevent mother-to-child transmission. Of course, those who qualify already for treatment, they should be already started on treatment and taken through the time, through their lifetime on the treatment. And so that is what is happening in this country now. And I want to thank the government of the country as well as the partners, including Chai, that we are able now to do what we are doing. And we've just completed writing the national guideline, which we are now disseminating. And I think things are going well. I think if we have this kind of commitment, especially from government, to work together with academia and the other partners, we should be able to achieve what we need to achieve. Thank you so much.
Fantastic, Professor Fonsano. I'm always happy when I see you. You are such a very pragmatic hepatologist. You are a hepatologist, yet you always wear the cap of the public health, because that is the approach towards elimination. If elimination doesn't go to public health space, we're never gonna achieve elimination by 2030. So thank you so much, Professor Fonsano. I think it's fantastic having you. Now, I would really go to before we go on, want to bring Dr. Musab Siddiq. Dr. Musab Siddiq is a public health specialist who previously shared as the Director of Disease Control, Director of Federal Ministry of Health, and currently holds the position of Director General for Primary Healthcare. I'm so interested to really get to hear what Dr. Musab said. More so that we're talking of integration. Dr. Musa, what would you say that you need to do differently? Hepatitis care across most African countries is in urban centralized facilities. Now I'm happy the knife, like in Nigeria, we say the knife and the yam is in your hands, meaning you have the power in collaboration with others to integrate hepatitis care into primary health care at the lower level of care. So Dr. Musa, and it's good to know that you've contributed to numerous scientific articles and policy documents, but it's time to act now. So what would you do in Sudan to make sure care goes to that level of care? Dr. Musa Siddiq, thanks for having you. And the floor is now yours to tell us your perspective on acting now to make the difference.
Thank you. Thank you very much, Dr. Danjuma. Before going into the integration issue, please allow me to welcome Professor John, Dr. Emmanuel, Professor Tassiano, Dr. Israel, Dr. Abdul Munim, and I'm also recognizing the presence of His Excellency here, Dr. Heitham, and I saw some of our professors, Dr. Al-Fatih Malik, and all the colleagues from other countries. Welcome very much to this webinar. And again, I would like to thank Professor John for this very kind invitation to join the coalition. And as the director of PHEC, Federal Minister of Health, I would assure you that the invitation will be formally accepted soon, inshallah, and we will communicate to you through the various emails you share. Because I like how Danjuma enthusiastic words was given. He heard a lot. Now he need to see an action. So I think this is the first action we will come out of this. We will start by joining the coalition immediately. And also I want to reassure you, if you didn't hear Dr. Sarah, that Sudan received hepatitis B first dose, and also add an action by the mid of December, inshallah, we will start the campaign for the first dose of hepatitis B first dose. Thank you very much, Emmanuel, for this very, very elaborate presentation, and thank you, Professor Passiano, for your kind notes. At the beginning, as Dr. Danjuma said, I thought you are a public health expert, not a gastroenterologist. It's really interesting to see what's happening in Uganda. I'm really appreciated this. Uh, for me, uh, hepatitis B, despite all the work we have done in the past, starting from the national strategy, for me, there is always a lack of some information in Sudan. We had never been having a seroprevalence survey. We never know the magnitude of the problem in Sudan. My own belief from the data I saw from the reports, although it is not a structural survey, but the prevalence of hepatitis B in Sudan could be one of the highest prevalence in Africa or in Eastern Mediterranean region. So for me, I think we really need to collaborate very much with our professors in academia here to think about the way on how to getting a real or if not 100% real, but a very close prevalence survey for hepatitis B, which will help us to shape our efforts in the future. There is also an urgent actions need to be done. And I'm happy that now hepatitis B first dose is going to be implemented, but also expansion of the testing among pregnant ladies, high risk groups in prisons, uh, healthcare workers. This is also need to be expedited a little bit. In addition to that, updates of the strategy, because our strategy ended 2025, I think. Correct me, sorry if I'm wrong. And other policies, like introducing the policy of vaccinating all pregnant women. It has to be a national policy and adopted immediately. In addition to the guidelines, because I think now we have an opportunity. WHO now adopting a simplified protocol to initiate the treatment without a complicated, diagnostic test or this. So we should grab this opportunity and adopt our new guidelines, especially that I heard there is a new reduced price pre-qualified drugs which the country could search for resource for it to include it in the national guidelines. The other opportunity for the hepatitis B is about the data. Without accurate data, we are going to lose the track. And I'm happy about the experience of Uganda in integrating the data in the different platforms. Here in Sudan, we have a very strong platforms working now, like the DHIS2, and there is an effort to include the hepatitis B, all indicators in the DHIS2. In addition to that, the IDSR, integrated disease surveillance. So it's become a reported, disease, and we could see it in the emergency operating center. So coming back to the question about the integration, uh, uh, I'm happy that to assure you, Dr. Danjuma, that we have already started the integration of hepatitis B, first of all, with the HIV program. And as Professor John mentioned earlier, and Emmanuel also mentioned in his presentation, now the Global Fund is supporting the HIV testing, the hepatitis B testing. We included in the previous grant cycle, DC7, and we are planning to continue the procurement of the hepatitis B testing through the Global Fund grant. Despite the diminishing the financial landscape, but we will insist to have the hepatitis B testing included in the upcoming grants. And now we are conducting the testing integrated in the BDI site, in the HIV BDI sites, but also with the efforts of the national centers, there is a huge effort of doing a testing campaigns among the risk group. Other platform, which is way to like a venue for integration, is the mother and child health programs, including the EBI. And you can see it is already now the vaccination campaign will be completely done through the routine EBI system. And in addition to that, we have a very, very excellent platform, which is the antenatal care level, and that's why I'm insisting that updating the policy, like strengthening the testing for all pregnant women and ladies. Other policy, I'm very interested to update it as soon as possible in the national drug list to include all newly pre-qualified medicine to include it so as we could facilitate the introduction of the new the new treatment and the new medicines in this. Thank you, and over to you, Dr. Danjuma.
Thank you so much, Dr. Musab. I mean, that was fantastic. It's great to hear from you. Before we move on, distinguished colleagues, ladies and gentlemen, I really, really want us to, the person I'm going to call now is a great friend. Like when Dr. Mead mentioned earlier, the meeting we had in Kigali was both the African Hepatitis Summit and also the African CDC regional meeting. And the gentleman who facilitated the African CDC meeting is no other person but this my great friend, Dr. Rene Robert Mendo. I mean, Dr. Rene is just a fantastic guy. Though, unfortunately, the community groups that were there really were so emotional when Dr. Rene told us, oh, he has to jump to start. But Rene now have started a very great move with ADAN, a non-profit, and he serves as a technical officer with the WHO, the African CDC, and also working now with a non-profit, which is also willing to support Sudan and dedicated to health-related work. So I will really, really, it's an honor for me to call on my great friend, Dr. Rene, to share his perspective on the act now. What could we do differently in terms of community engagement, in terms of strengthening partnership with government, in terms of what do you think Sudan should do differently? And you've been in that space, you've supported the government of Sudan, and you've been in that space. And so, Dr. Rene, I think want to pick your brain on this. And yeah, over to you, my great friend and wonderful colleague, Dr. Rene.
Welcome, Dr. Rene. Feel free to unmute yourself, please. Dr. Rene Mendo, you're a co-host, so you can mute and unmute yourself.
Rene is having challenges to unmute his microphone, so is it possible to have
Let
someone?
me try once more. So
Yeah.
I'm asking him to unmute now, and he's a co-host, so he can.
Yes.
Perfect.
Now I'm able to. Yeah, that's fine. Thank you.
Great to have you with us today. Thank you.
Yeah, thank you. Thank you. Thanks. Thanks for all the team who has been able to organize it. Thanks Danjuma. Thanks Dr. Abdel Munem and all the entire team from Sudan. And it's really an honor and a pleasure to be here. And first, I would like to thank His Excellency for being there. If I'm able to share my screen, I prepared just a very short slide to give my perspective, and I hope you are really able to hear me loud and clear.
All clear.
Okay, that's fine. Thank you. So basically, I've been leading Hepatitis at Africa CDC since the past 2 years and a bit more. And I saw many things that are very important from the perspective of fighting against hepatitis, and also looking about what is necessary from my understanding as a push to reverse or to put on track the response. So basically, we know that the situation is really concerning about hepatitis, and if we look about the most recent WHO global reports, we can see that Africa plays a very strong have a very strong burden when it comes to hepatitis B and C, and most of the new infection, for example, for hepatitis B, occurs in Africa, the new infections. And because of many reasons, but most importantly, because of the low vaccine coverage for the birth dose, but also it appears that there is a lack of, like it was said by Danjuma, there's a lack of prevention and control measures when it comes to the screening. Very limited number, very few number of people are screened, but also many people are not put on treatment, which is very concerning. And this, it could be the same also if we look about the hepatitis C. But I think one other thing is that hepatitis D data is also there, and we don't talk much about it. But there is also something that we should always consider, that it's a lot of reinfection that we always don't think about, but it will come out most prominently as something very urgent to think about from the coming years. So we are in a mix of challenge and opportunities. So we have a lot of tools. I think the first one for Africa, which can reverse and put us on track, is the birth dose. And I think if we are able to ensure that at least 90% of children which are born can be born and put on hepatitis B, can be vaccinated, we are quite sure that now we can stop mother to child transmission. But it's not easy, because we need to push and to continue to advocate and also document some of the essential needs for NITACs to take decision. But also we have a lot of diagnostics, which are quite some of them affordable, but there is a lot of variability between countries. For example, you have some diagnostic which can have a high cost in Nigeria, but others which can have a very low cost. So for that, there is something that I remember at Africa CDC, we were working on to try to establish a pool procurement platform to ensure that we can negotiate and access pricing for Africa. But this is where I think all of us should work on: civil society, technical and financial partners, and also government, to work on this common way to find the negotiated pricing. We have treatments which are quite a very good efficacy. And one of the tools is the possibility we have existing program. Most importantly, HIV program are established in all our country. But what is difficult is that we have current barriers, which are barriers of our time now. For example, the first one we talk about is about the funding, which has declined. And there are many priorities. If you look at situation of Sudan with the war, there is a lot of priorities, and for basic services and others, which are quite important, all of them. But also we cannot forget about the stigma, the role stigma is playing to limit access to some of the services which are in some of the contexts available. But also we have the health system which are quite fragmented. If you look at the programming, we look about access, the fact that all of our hepatitis services are, most of them, high specialized, and we have a limited number of gastroenterologists. And also about the mapping of our services, sometimes you have to go very far to find the health services, and the availability of resources is also limited. So I think our goal to have this final push should be to have a kind of a cohesive strategy, not just a checklist where we ensure that everything is there, but this should be done in certain coherence to ensure that we can all have things that could be smooth, to ensure that we can have a good service delivery. And for me, I saw from my experience that there are three pillars that we should take in consideration. The first one is about the political will, and we have two pictures, for example, on the right side. We have seen how Egypt has been able to demonstrate capability to reach the Gold Tier C certification. We also saw Namibia, which has been able to get the certification for elimination or to mother-to-child transmission, HIV, TB. So all of this start with a very strong political commitment. And we are quite happy because His Excellency is there, and it just reinforces the fact that it's a hand-on-hand work that we will be working on. And for that, we need a lot of domestic resources. And normally, the response has been guided for the past decades by many international partners. But now, we should reverse this trend with more ownership on the response. And then it is also where civil society plays a role, because civil society, we are part of the communities. We are resources. We are an asset. So we will be working now to support this strong political commitment, and also we will be part of the response. We should be at the center of the response. But also we cannot guide the political response, or we cannot guide the strategy to elimination without getting any data. This is where, for example, surveys and national representative data is very important. This will help to track and measure how we are going forward, prevalence, also document impact of vaccine that we are doing, especially from the postcode from the 20s years that we have been. So all of this can be a very good combination to ensure that we put the response on the track, not only at national, but also further. The second areas for me that I saw also is that we should have a kind of integrated and patient-centered approach for our health systems. We have health systems, and we have different level of care and services and health system tier levels. But when we go in the reality, there is no integration. There is a limited integration in our health services. Normally, we should have very strong nexus, if I can say it like that, of continuum of care between the ANC, PMTCT, and maternal and neonatal care services and others, to ensure that every woman can be screened, part of the ANC's systematic visit, and then put on treatment, and then also for the children to receive the vaccination and then continuum of care. And so this is a kind of continuum of care that should be very systematic. And for that, it needs to update the guidelines. It needs to ensure that we have sufficient access to IVDs, to treatment drugs. But also one other point is also that we should we should have a very strong blood safety in our systems, in our countries, which is something that is sometimes not visible or sometimes left out of our action and activities. But also we should start to fight really with the latest energy stigma, which is, for me, I think it should be included in the curriculum from the medical studies, from nurse studies, and also further when it's go to the practice. And then for the last pillar, for me, I think it's about the social mobilization and what is related to community engagement. If we look at, from my own opinion, and I think it should be the same, when we go to the countries, we say, okay, there is HIV, everyone was HIV. But if we talk about hepatitis, it remained very limited knowledge about hepatitis, even in our health practitioner level or medical or care provider level. And this result in a kind of negative seeking behavior or limited seeking behavior, misinformation, and many, many other things. I think we should definitely start to run comprehensive public awareness campaigns. And for that, we have a lot of tools now. We have social medias, we have TikTok, other things that can help us to reach more people with less funding and we should work with influencers. We should work with people who are talking to our youth, because now the youth represent the majority of our population. So this is exactly where now we should invest. And it's really efficient and it's really low cost. And I think also at this level, we should increase multi-sectoral collaboration, because when we talk about sensitization and multi-sectoral collaboration, we should look, for example, at education, because it's direct to the fact that curriculum, trainings, teachers, and others. But I see also other areas, for example, the police, labor, for ensuring enforcement in policies, for example, if we have to recruit people, ensuring that we can systemize medical checking in the labor market, but also other sectors where we have high risk people, like for example police, army. We should scale up prevention and control policies at this level. I think it's very essential. So I think these are for me the essential point that, for example, in my perspective, we should be working on and ensuring that we can demonstrate a pragmatic approach when we want to address now viral hepatitis. Who we are, Adan, it's an association who is working on health, especially in the area of development, in humanitarian, and also the nexus, which is kind of continuum between the health and the humanitarian sector. It is a civil society organization. We are partnering with a national program to accelerate support and especially technical assistance toward hepatitis elimination. We are currently working with few countries. We are working with Madagascar. We are working with Cameroon. We are also trying to expand our collaboration currently with other countries. So we provide pro bono, so it's a free basis support to countries, especially for technical assistance, to ensure that if, for example, countries have some areas where they are able or they need some support, we can, for example, support review and update some of the strategic document, technical documents. We can also support facilitate trainings and support integration model scenarios and planning into the health services and existing platforms. But also we support some kind of design and implementation of public awareness campaigns. Our main vision is that we believe that sustainable elimination is really built on strong local systems. And when we say local, it really includes community, people affected by the disease. And we hope to build with them together to achieve the elimination. Thank you, Danchuma, and
Yeah.
thank you for all the people for your kind attention.
Thank you, Rene. Before I drop off, actually, I've already said Shukran Salama because I need to drop off for another meeting. But Dr. Rene, I really want to put you on the spot. How will Aden support Sudan? In what ways would you support Sudan towards most of those ideals you mentioned? And especially now looking at stigma, I don't know what is the context of stigma in Sudan in terms of the cultural barriers, the structural barriers. So in what ways would Aden help support Sudan towards this? And you contributed to this, Rene. You played a significant role in even making this happen. You were really the brain behind the regional workshop for African CDC. Now transitioning to this now, in what ways would you bring this expertise to support a country like Sudan towards their wonderful goal? Over to you, Rene. And I want you to act now. I want you to really, really act now and tell me specific, tangible steps you want to do. And in terms of stigma, in terms of commitment, what will you do, Dr. Rene, to help?
Yeah, thank you. I think all of this starts with a proper engagement with the Sudan team. I think the good thing is that through the program we had in Kigali, we have established, we have identified critical areas that a Sudan team needs to the key milestone, we can say it like that, the key milestone the Sudan team want to achieve, and what are the current bottlenecks that are identified. The specific, for me, the specific situation of Sudan is also, Sudan is in a specific security challenge, especially with the war. And at this level, this is where I think the ADAN can have an integrated approach, because it look about the humanitarian and the development needs for health specifically. So basically, it will work at three different layers. The first one will be to support the country to understand the needs from the community in both specific contexts where there is a crisis, to ensure that, for example, some kind of possibility activities targeting some possibility people affected by the crisis are taken in consideration, but also ensuring that we can have a kind of strong system in place to ensure continuity of activity, building a foundation, if I can say it like that. The second area, I think, is about working in the policy, what can be adapted in the policy, what is needed in terms of, for example, research to ensure that we can provide mental health and psychological support for people affected, integrated into the policy of care and the service delivery, but also building a training package. This will be also one of the points where, for example, Adan is really to support the Sudan team. And then at more strategic level, to understand how we can work, for example, with some partners like Africa CDC, which has established a program for mental health and stigma within the division, the Center for Primary Health Care, which can complement this support and also provide some kind of why not funding or technical assistance with other global partners to ensure that this is mainstream, and also Sudan can benefit from this kind of support to ensure that this can be a kind of continuity, not only for hepatitis, but also for other programs, which can be, for example, HIV, other non-communicable disease, and others program at the level of the health workforce in Sudan. So basically, that's it. And I think we are really keen. I know we had some discussion also part of the training, but I would like also to emphasize that our organization is working closely with Africa CDC, and then we are also trying to identify what are the potential continuity of activities that countries can benefit from Africa CDC and for us in that way. I try to respond very quickly. Thank you.
Yeah, thank you, Dr. Raine. Over to you, Dr. Zilal, and thanks, colleagues. Bye, everyone.
Thank you so much, Dr. Danjuma and Dr. Raine, for sharing such amazing experiences and the willingness to help Sudan during this time of crisis. The knowledge transfer and the sharing of knowledge is the basic of how we evolve and we achieve the hepatitis B free African continent. And I can see that happening with collaboration of amazing people like yourself. Thanks everyone for sharing. Now we've 11 priorities. All right. These priorities are shared with you in the chat box. First is the strong political commitment and willingness that was elaborated by His Excellency, Dr. Heitham M Ibrahim. The second priority is the nationally representative surveys for prevalence that was covered by Dr. Sarah Azhari and Dr. Musab Siddiq. Thank you so much for your time and effort. Now, going to priority number 3, we're talking about education of the healthcare providers and to combat the stigma. I mean, when we talk about that, we need integrating the training into the medical and nursing, all the healthcare providers, because during my 9 years of practice, I've seen so many healthcare workers have the stigma about the virus and being infected or dealing with infected people. Then we need to address providing the level of discrimination among patients and healthcare workers, and would like to explore what role of the professional councils such as the Sudan Medical Council and Sudan Medical Specialization Board. It's my pleasure to introduce the distinguished speakers or panelists today. They're my mentors and leaders in hepatology. Dr. Sarah Dafa'Allah Al-Haj, she is a consultant gastroenterologist and a transplant hepatologist. She is a highly respected consultant known for her expertise in advanced hepatology and liver transplant, of course, management of the viral hepatitis. And I would like to introduce Dr. Salma Barakat. She is a consultant gastroenterologist and hepatologist. She is one of the pioneers who established outpatient services for hepatitis B viruses in Sudan, and she is currently practicing in the Royal Cornwall Hospital in the UK, along with Dr. Hala Abul Hassan. They're pioneers in this service and they shape our future. So can you tell us more about the education of the healthcare providers and the stigma?
أبدأ أنا. السلام
Yes,
عليكم.
please.
Thank you very much for this meeting. I think it was really my honor to attend and listen to the professors who have so much experience and the other colleagues from countries who have the same probably challenges we have and have managed to do so much. I was also happy to listen to Dr. Heitham, and I know he is a very committed person. Even when I was in Sudan, he was always there to help, despite all the challenges in the country. Regarding training and teaching, as a national center, I think my colleagues can also vouch for it, because to be honest, for a long time, it felt that we were the only ones who were concerned and fighting for hepatitis B to be well recognized as a problem and to be managed properly. It's not one of the priorities in Sudan, unfortunately, for the Ministry of Health. And I think the commitment should be, number one, to make it one of these diseases. It has to be included in the list, because it's not, I mean, you can say we are biased because we're hepatologists, we see the end results and we see young people die with hepatitis B. But at the end of the day, it's part of management of all diseases. So the surgeons are impacted, the gynecology, the pediatrics, everyone is in, the police force, everyone is impacted by this disease, and it's everywhere. And everyone has to be involved in the management, and it has to be a priority in the country. It has to be a priority. Okay, saying you're committed, it's not enough. It has to be a priority. It has to be a mass movement from everyone, from primary healthcare, from the obstetricians, from the educational system, from the police. As was said and mentioned, it's something affecting everyone in Sudan. And if we don't act as a complete group, and if we don't acknowledge that it's important, we will go nowhere and we'll be saying the same things. I agree with all that was said, all right? And I agree that there are so many facets to managing it. And I think this is a good forum to sit together, and because no one can do, you can't clap with one hand. We need more hands, and it has to be integrated in everywhere. And everyone has to know where their role is and just stick to their role. Okay? Regarding going back to your question, sorry. regarding the question, it has been part of the teaching. We teach registrars all the time. We started the campaign like teaching campaigns. We did lectures for the family doctors because we thought they were important part, and they see patients in the community, and we thought we'll start with them. There was a plan to give further teaching for other specialities. We did teaching for the maternity hospital, not everyone, but we even did 2 sessions, one for the doctors and one for the midwives. And I think it can go on. There's no problem. That's the cheapest way. This is something we can do, and it's quite cheap. It will not cost us anything, and we can continue with this program. And this is what we've been talking about. Me and Sarah and Hala, I'm sure, would be part of the team and the others. And we can just continue with the training and teaching of the staff, doctors. We need the university and higher education to be involved to start this. And we are happy to prepare a curriculum or a teaching lectures or whatever for all levels. And I think this is something that can be delivered through the National Center. I don't want to speak too much. I'll leave some points for Hala and Sarah to say. And thank you very much.
Dr. Hala, Dr. Sarah, your co-host, feel free to unmute yourself. And looking forward to hearing from you when it comes to stigma. I know you've long experience in the clinical settings, and of course, as mentors and trainers, what do you have to say about stigma?
Salam.
Go ahead, Hala.
Okay, salam and good evening. Thank you, Dr. Zulal. Really, I can't express my happiness and appreciation regarding this major step. Today really is this prestigious national and regional collaboration to combat hepatitis B virus. It is our great dream since long time. I enjoyed the Dr. Danjuma talk, and Dr. Renee and Dr. Emmanuel. Unfortunately, really, in Sudan, we are lagging behind because hepatitis B is a major stigma in our country, unfortunately, even among educated people. Many students lost their universities, and we have many sad stories that primary school students kicked out of their school because their father is discovered hepatitis B virus, died of HCC and hepatitis B. Many employees lost their jobs, even in the banks, even in maybe military and everywhere. So our poor hepatitis B patient were suffering a lot from viral hepatitis, not from the expensive blood test or investigations or the unavailable medication that which is not registered in our country. And unfortunately, after the war also, our problem is being more complex. But the stigma, we have a real stigma, and we need to work a lot for to solve the stigma. Unfortunately, this stigma might be even among doctors. So we need to start with education and awareness program for the medical staff and for the public. The National Center for Dry Liver Disease have many campaigns, and really today, as we see in any talk and presentation, the first thing mentioned is stakeholder collaboration and stakeholder commitment. So seeing His Excellency Dr. Heitham, Dr. Sarah, and Dr. Mus'ab, today really we are very happy for this great step. We are looking forward to lead the same lead of Uganda and other African country, and we are waiting for major collaboration to combat hepatitis B virus. Thank you for this day, and up to Sarah.
Assalamu alaikum. Hello, everyone. Thank you very much, Hala and Selma. And to start with, I want to thank everyone here today and to thank our regional and international speakers for sharing their experiences, sharing their knowledge, and sharing with us the opportunities that Sudan can make use of with regards to collaboration with regional and international entities to support and help our fight against viral hepatitis. I'm in complete agreement with almost everything that was said. I will start with I have 2 points actually, one with the education, and there's another one about integration. So regarding education, as mentioned by Hala and Selma, the National Center, either alone or in collaboration with the Ministry of Health, have conducted many sessions, and as Dr. Selma mentioned, there was a plan that we at the National Center have put forward with regards to education. In education, we have unfortunately to deal with 2 things: the lack of information and the misinformation. Because many of the stigma comes or stems out of pseudo knowledge, people who think they know about the disease, but they disseminate wrong information. As discussed in the previous sessions, and I hope this will change now with the very appreciated Ministry of Health commitment and political commitment, is that I think once the hepatitis or viral hepatitis is put as a priority, this will change a lot of things and should have a domino effect with regards to how our curricula are designed in terms of that, putting hepatitis B education and hepatitis B as a priority, because we've discussed that hepatitis B is not taught the same way malaria and TB are taught in our medical schools or health care related schools. In terms of the training, and as Dr. Selma mentioned, the board for the family medicine were very committed and asked the National Center to have a whole day training for their trainees, which was mandatory. And I think this should be a core training for all the medical specialties, all the laboratory and nursing, and we should have a core training for everyone working in a health facility to protect themselves and to protect others. So I think here, as mentioned by Dr. Selma Barakat, this can be done even now. We can continue virtually, and we will be starting with the dialysis nurses soon, inshallah, which is this activity stemmed from this platform. So I think education in the medical field, and again, education raising awareness of the public with the right information. And I think there's other sectors that need education, which is basically to give the right information to people working in the different government sectors, because most of the tragedies we see from stigma, they stem from also other sectors in the government, the education sector, higher education, the police force, I mean, everyone, the judiciary. So there's stigma ingrained in the system, and I think this needs a lot of work from everyone. The second point, which is related to the stigma, and I think it's important when we're thinking about integration of the hepatitis B or the viral hepatitis services into the already existing services. I know it makes sense that the services will be to be integrated with the HIV to make use of their long history and long and well-established services. But I think we need to, when we're planning this, we need to be very careful. And I think integrating the hepatitis B services into the primary healthcare would be the way to go in Sudan, because hepatitis B virus stigma is already established, and we do have an HIV stigma. It might be a little bit different from other African countries where they have had a long history of working with HIV. The prevalence of HIV is more than in Sudan, and I think the communities there probably the stigma is not as much as in Sudan. Yes, I think we HIV program and primary health care can collaborate at a higher level, but I think it is important to consider the social stigma related to hepatitis or viral hepatitis patients going to HIV centers or receiving treatment there. Thank you very much. I think that's about everything I would like to say. Again, I would like to thank everyone, and I highly appreciate the Ministry of Health commitment, as Dr. Selma said, at last we feel that we're not alone in this fight, and we just have to remember that this is everyone's battle. It's not the battle of the Ministry of Health alone. It's not the battle of the health sector alone. It's everyone's battle, including the public, who have to be really engaged. And I'm very happy that Adan and Dr. Renee mentioned about helping and supporting the systems to listen to the community and to understand the needs of the community from within. Thank you very much for this opportunity, and thank you for this platform.
Thank you so much, Dr. Selma Barakat, Dr. Hala Al-Hasma, and Dr. Sarah Dafa'allah. Well said and very well articulated. And that's our battle. You will not walk alone. We're all here to fight hepatitis B together. Now, going forward, and thank you, Dr. Rini Herbert-Mendo, for your speech and your support from Adan to Sudan. And thanks to Dr. Danjuma. He's truly inspiring. Thanks for everyone who took their time to participate in this session. That means a lot to us. Thank you so much. Now, we've 11 priorities and we covered few points. Going to the next point, and me personally believe that's the most important priority among these, and that's community engagement and participation. When we talk about that, we're talking about using newer platforms such as social media, involving the youth networks and the patient groups, support groups for the patients and the caregivers, and correcting the misconceptions on transmission, disease course, the deadliness, and sure, the community-led advocacy, given Sudan has special circumstances when it comes to community. Dr. Abdel Mun'im Al-Tayyib Abdo, he is the director of the National Gastroenterology and liver diseases. And he's an amazing intervention gastroenterologist and hepatologist. During his time, we were proudly witnessing the very first liver transplant. Over to you, Dr. Abdel Munem, to elaborate on community engagement.
Okay, thank you, my friends, international experts who join us today. Really, we are very happy that you are here, and really, I would like to see Chai and Ada in Sudan, and really they did a great job in other countries, and we would love to see them in our country. And really, I'm happy of the success of this meeting, and now we can see clearly that we are as clinicians and together with the community physicians and with the Minister of Health, working together and no more dichotomy. And I'm glad for this. And really, we need practical, action for this from this meeting. So we need the political commitment. We need funding, really, before going to the budget of the new year. We need fund to combat hepatitis B infection. We have still problem which not addressed today in this, maybe in the last meeting. There is no drug in the country. I talked to the Undersecretary, Dr. Ali, and he was supposed to to join us. I don't know, maybe he has some encounter some problem to join or something, because we had problem with link. We talk about the drugs and availability of the drugs, and he is ready to facilitate any efforts to have drugs, because now there is no hepatitis B drug in market. Really, this is a big problem, and quality of testing as well. And I hope we will see an effort in improving the DHIS2 data and work with people in Ministry of Health to work on improving the collecting data from DHIS2 and having good quality tests to rely on to have true prevalence, because we know that the surveillance, to do a surveillance is very expensive and need a lot of funding to do this. Regarding the community engagement, I think we need more work, is education. We need to include this maybe in the curriculum in the schools. We need to have more organizations, patients organizations like hepatitis B organizations to work on educating people about hepatitis B infection. We need more work from the university. I think we need more efforts from our side to educate doctors themselves, because as Dr. Hala said, even the socialist, the stigma from hepatitis B, even among doctors, we see this. So we need to do more efforts regarding education, doctors, educations, healthcare worker, and to involve more organizations, local organizations to work on hepatitis B infection education. Thank you.
Thank you so much. And we have much more to say. And that's priority number 5. It's integrating the hepatitis B service at primary health and antenatal care level. We need to publish or widen the universal testing and linkage with the care at the primary health level. Ensure screening all the pregnant ladies and the birth dose vaccine. Many thanks to Dr. Sarah Azhari, Dr. Musab, and our inspiring leader, His Excellency Dr. Heitham. Dr. Sarah Azhari, can you collaborate more on the integration of hepatitis B service in the primary health level and the antenatal care, please, and thank you.
Okay, thank you, Delal, and for all of the speakers regarding their kind words and in their also commitment to support Sudan. It is quite well appreciated. I hope you can hear me clearly. Delal, please confirm.
Yes, we do. Thank you so much.
Okay, thank you. So since the development of the strategy, the approach was to integrate the hepatitis effort across all the available services and available entry of point of interest. So the initial plan is to integrate because we identified high-risk groups, and those high-risk groups are speaking for a specific high-risk group like PLHIV and prisoners and also key population. And those specifically are served through specialized care centers. And we needed to integrate the service of the viral hepatitis to their centers and to avoid creating a parallel system for them. For the other groups, like the general population group, we will integrate the viral hepatitis services in the BHC, and would be one of the essential benefit package of the BHC, testing of viral hepatitis through rapid diagnostic test, and to refer for needed additional needed management across the BHC also. For the ANC and for pregnant women, we already integrated the ANC, and as Dr. Musab was saying, that we are in the process of updating the policy of the ANC and to use the simplified WHO guideline to serve the pregnant women, and this service already will be integrated to the ANC across the states through ANC facilities in the country, along with HIV and syphilis as one package of viral services provided to those states. So the approach is to integrate viral hepatitis in the already existing outlets and services in order to get the maximum and to maximize the benefit of having those services integrated. And as also we spoke about the integration of viral hepatitis function into the immunization or the EPI program, and it is proved now by having them leading the introduction of viral hepatitis bears those into the country. And this is the integration is our approach, as it is the way for sustainable services across the country, and to maximize the benefit of all already existing efforts to fight any disease or to provide any service. So this is regarding the integration, Bilal, and let me assure Dr. Sarah, because she's always pointing to that they are afraid of having integration of viral hepatitis services into the HIV centers. It is not for the general population. It is only for the BLHIV and for the key population who are one of the high-risk group. But for the general population, it will be integrated in the PHC centers in order to serve all the general population and to serve it as a regular routine service with along with the other essential benefit packages of the BHC. Thank you, and over to you.
That is fantastic, and thank you so much for supporting this platform. Thank you for spreading the word on the behalf of the Federal Ministry of Health, and much thanks for the strong political willingness to make change and make it reality. Now, we need to talk about updating the current national guidelines to align with the WHO standards. And of course, as a country during the wartime, we face many challenges, specifically drug availability, the follow-up and monitoring for patients across the country. And of course, we need to involve clinicians, pharmacists, lab technicians, and scientists, and the policymakers as well. Dr. Zainab Abdelmajid, she's a brilliant gastroenterologist and hepatologist, and she's numerous research work. And she gave an amazing lecture on the local guidelines compared to the WHO standard guidelines. Can you elaborate more whether we can align both or we can have more meetings, talks to make it possible? Over to you, Dr. Zainab.
Assalamu alaikum. It was a great day that we had all this collaboration from all the parties that we met in Kigali, and really happy to hear the voice of Dr. Heitham. We're so thankful for his presence today. So regarding the part of how updating our guidelines to align with the WHO guidelines, the recent guidelines that were released by the WHO seemed very simple. And if you are in a remote village, you can simply treat HBV without needing so sophisticated test or very complicated test. So it seems very easily to stick patients to offer treatment very easily to patients. But the question is, you have to remember that treatment of HBV is in most instances a lifelong treatment. So if I'm going to be giving a patient treatment for lifelong, so I have to put on my mind who will offer this treatment all this time. It's not a 1 month or 2 month treatment. It's a treatment for lifelong. So when I put this in my mind, so I should just think, is it possible for my patients to be given this treatment, which may be to some extent very expensive to some patients, especially in circumstances of war in which people have a lot of burden on just having food. So treatment will be some sort of luxury for them. So I think in our context, we have to put this in mind, the issue that treatment is not offered for free. Patients have to pay off pocket for their treatment. So so if I end up having so many patients eligible for treatment, I will end up at the end of the day with a lot of them dropping off treatment, and which this might raise concerns of having more resistance. So I think we should be very careful in adopting the WHO guidelines in our context, and I think this should involve all the politics, involve the industrial companies of pharmaceuticals, so that we can come up with an agreement with a very much cheap medications, so that we can, if we are going to be going with on the same way on the WHO guidelines. Thank you.
Thank you so much, and well said. So hopefully we'll see that happening one day once we establish a clear pathway and free or near free access to hepatitis B medications, vaccinations, surveys, and a wider region. I would like to welcome our mentor and our biggest supporter, Professor Ali Habour. He served as a dean of the School of Medicine, Jazeera University. His numerous research work in regards to pediatrics and tropical medicine in pediatrics and child health. And of course, he's a member of the committee that give permission for those vaccines to take place. Prof. Habour, can you tell us about the public awareness using mass media, using platforms like universities to spread the word? Of course, storytelling, and you've long experience. How can we reduce the stigma and employ and strengthen the public awareness campaign?
طيب بسم الله الرحمن الرحيم. سامعني يا زلال. Can you hear me?
سامعينك يا بروف. مرحبا بك.
طيب thank you very much for your continuous activities addressing tropical diseases. And in the last few weeks, I've been addressing hepatitis B. I'm very glad with this international collaboration. It's very good that we hear from our colleagues from Africa, because most of the time we've been looking north. I think we need to look south a little bit, and they have got a lot of experience and collaboration with the international organization. I think the strategy presented by our colleagues from Rwanda is an excellent strategy, and I think we should get use of it, or at least adopt most of these areas which they have presented. It's a very good strategy, and it has got good results which they presented. The other thing is that I'm not sure whether, as Abdulmunim, are there a national program for control? We've got a national program for control of malaria, a national program for control of tuberculosis, national program for control of diarrheal disease, and so on. And I'm not sure whether Nas Abdulmunim have got the same strategy of the national program of control of malaria, and so on. If not, then the Ministry of Health has to have this program parallel with other programs like malaria. The other thing which I would like Abdulmunim and those our colleagues is to design or write a very good lecture addressing clinical features, etiology, investigation, and this lecture should be distributed to our colleagues in medical school, in nursing school, and so on, to be presented to the student. This is very important. أنا أفتكر كده. يعني هسه أنا عندنا في الملاريا we've got a model lecture. في tuberculosis there is a model lecture. This model lecture was written with the School of Tropical Disease in Liverpool, and I think we are now in a position that Abdulmunim, we can design a lecture, model lecture, to be given to the student as part of our academic activities. This is one thing. The other thing is that I'm very glad that in the NITAC, now we are introducing zero hepatitis B vaccine, which I'm sure will cover the area of a gap between birth and 40 days when we start the Penta. You know that the Penta vaccine includes hepatitis B. Don't forget the midwives, please. I think the midwife school should be addressed, and we've got thousands of midwives spreading all over Sudan. We should include them in our advocacy program, because the midwives are the ladies who are in contact with pregnant women, and I think we should give them a place in the advocacy. This is very important, and I'm sure in the coming few years we'll have very good results in these collaborative efforts. Now, in the past, hepatitis is just given as an infection. It's not given as a community problem. And by addressing it now as a community problem, I think this will have good results in the future. It's a very good effort, and I thanks all those who are really providing this good information. We need to educate our colleagues in the medical schools, in the nursing school, and laboratory departments in different universities. Our students are now engaged in community courses, and 25% of the community-oriented medical school, their courses are in the community.
and we should skill our student with this information to be presented in the villages when they go to the health centers or the villages or the district hospitals. Thank you very much, Zilal and all the colleagues, and I'm quite happy. A leaflet should be given to us about this يعني لما تقول a model lecture. What do you want us to say to our students in the medical school? Thank you very much.
Thank you so much, Prof. Habur, for your support. And of course, we circulate all the materials on our YouTube, Telegram, and WhatsApp channels for access to the public. And of course, we can form kind of a small work group to get the best knowledge and share the knowledge in between us. I would like to welcome Dr. Al-Fatih Malik. He's a associate professor, Faculty of Medicine, University of Khartoum, and he's a specialist in the public health and disease control. His interest in malaria and various communicable diseases, and he's a recognized epidemiologist and disease control specialist. He has a role in the WHO office and, of course, in the Ministry of Health. His numerous publications about various disease control. Dr. Al-Fatih Malik, our 11th priority is the cross-governmental collaboration to eliminate the structural stigma. And this can be implemented by working on education. Since the medical school, we talk about law enforcement sectors and, of course, reforming the discriminatory policies and protect the rights for people living with such disease. Dr. Al-Fatih Malik, you're most welcome among us, and over to you.
Thank you very much, Dilal, for the nice webinar. And thank you for extend to our colleague from the region. And we really appreciate their presentation on their experience in Uganda and other countries. Thank you for my colleague from Dr. Salma from UK and our colleagues and Professor Ali and all the speaker. And I appreciate that Dr. Heitham demonstrated his commitment to this by attending part of this webinar. I would like just to talk about 4 points briefly. One, to establish a control program, I think you need data. So you need to estimate, to assess the burden. And I think we have to do some desk analysis. And then if there is any pitfalls in the data, we have to complete by survey or anything. So I think this is a good starting point. And the second that we need to have, as Professor Ali stated, we need a strategy. And I think we have to work on that. The strategy is very important because it puts all the effort in one platform. And I think this is very important to go for elimination. So we need to exert more effort to have a strategy. If it is not there, and I understand that Dr. Tariq have do a lot of work in this area, Dr. Tariq Abdullah, when he is a disease control director. So I think we need at least to update. The third point is that to me, hepatitis is a behavior-related disease, and this is here comes a stigma. So I think we need to when you, if you want to deal with a disease with such stigmatized disease as you stated, I think we need to understand what is the behavior behind this. So first we need to do behavioral situation analysis, and then we need to establish our behavioral goal, and then we design what we need at that. Do we need health education for the public? Do you need education for the health personnel? Do we need? I think it should be an informed decision. So that's why we need this. And I think we need to encourage people to do research in this area. I think there is, we are lagging behind in this area compared with other prevalent disease in the country. So I think we need to encourage people to conduct researches in viral hepatitis in general and hepatitis B in particular. That is my contribution. Thank you very much.
Thank you so much. I would like to welcome Dr. Huda Haroon. She is a prominent figure in pediatrics and child health. And of course, when we talk about the 11 priorities, we particularly highlight the pediatric population antenatal care as well. Welcome, Dr. Huda. Thank you for being among us today. Over to you.
Yes, thank you very much. Assalamu alaikum wa rahmatullah. I think this is a very nice webinar. It shed light to many important points. I would like to say that do we need to screen the people at risk so as to know the prevalence of the carrier state in those who are working in the blood and blood product? I think this is it is a very important point to start with, to know where we are standing, and then from that we can move to decide what to do. I also agree with Dr. Malik. We need to work on hepatitis more researches, okay, because there is a dim area which we do not, we need to highlight it. We need to do preference of carrier in those who are in contact with blood and blood products, and the working population, doctor, nurses, and also we need, because they are in contact with the blood and the blood product, surgeon, obstetrician. I think we need to start by screening to see where we are, and then we can differentiate which type of researches we can work on. Thank you very much. Thank you very much. It is a great webinar. We learn a lot from it. Thank you very much.
Thank you for your kind words, Dr. Huda Haroon, and we always welcome our colleagues from different departments, because that's how we grow and we share knowledge, and we transfer our experiences among different disciplines. Now, talking about the blood and blood product safety, that's the priority number 8 in this declaration. And this will be committed and agreed upon by all the parties to make sure that we have safe blood and blood products dealing with transfusion. And of course, we talked on previous occasion on the mandatory anti-hepatitis B core and the NAT screening for all the blood donors. And of course, we need to strengthen in the national blood service capacity, along with the donor selection policies that strongly need to be revisited by the experts. And we hope for this forum to be the start for that, inshallah. Also, we need to make sure that we meet the WHO pre-qualified diagnostic kits in all the laboratories, because it's a big issue when practicing that many labs can give different results. And this was highlighted on a previous session as well. Now we open the questions and answers from the audience. Please raise your hands and we'll give you a chance, or you can type in the chat box. Any questions, recommendations, remarks? Yes, Dr. Yasser Hamad Al-Nil. He's a brilliant microbiologist in France, and he worked in Ibn Sina hospital. So, Dr. Yasser, please.
السلام عليكم.
وعليكم السلام ورحمة الله. نسمعك بوضوح.
Thank you, Dr. Zilal, and thank you all the team for the good efforts actually. Few comments uh, on patients, on stigma and patients. There is a web that this web name is happycommunity.com. This web is designed by Professor Thomas Tu. He's a virologist, molecular virologist in Australia, Westmead Institute for Medical Research, and he designed this group for people who infected with hepatitis B. This is a global website. All patients infected with hepatitis B in this group are educated, and this group is open for all patients from all over the world. There is education material, there is an area for investigation discussions, there is an area of even the discrimination, and all patients talk together, learn from each other, and actually this is very nice. I don't know whether this will be good for our patients, but if we make another one like this in Arabic, will be, I think, very good for our situation. This for patients' perspective. The second thing is related to the virus itself. When people go to HCV, they do test and treat. When they came to HBV, they do test and refer. When we came to HIV, we reach up to U equal U. I know this is very difficult. U equal U is very difficult with HBV. For me, as a virologist or microbiologist, this is very difficult to say U equal U in any situation of hepatitis B, but at least low equal low. I don't know if Dr. Ward is still here or no, because this discussion, I think, also started previously with him in another meeting. Because these viruses are different in pathobiology, in pathophysiology, in clinical scenarios, in behavior of the virus, but the action of test and refer during this time, I think we lost a lot of patients, especially in our situation in Sudan. And it's from my previous experience when I was medical officer. When I sent patients to Ibn Sina, most of them, I didn't found them in Ibn Sina in follow-up, and I found some of them go for a sheikh management like that. So uh, if we adopt and implement the WHO guideline, we can go for the test and treat. And I can add, and here also Professor Bani available and Professor Fatih Malik, test, treat, and notify. If we apply this, test, treat, and notify, and if we engage this with electronic system, for example, for notification and for surveillance, test, treat, and notify with expanded guidelines for treatment of or not restricted people like previous guideline, but if patient tested positive, treat him, notify for the ministry. At this point, we will know the burden of the disease. We treat the patient. We even the cost of treatment for complication will be reduced. Thank you, and hopefully we'll find a good result in our situation. Thank you, Dr. Dara.
Thank you so much, Dr. Yasser. And these are very important points mentioned by yourself as a virologist and someone who's involved in the clinical practice. And of course, we can revisit and small work groups to make this happen. I would like to welcome Professor Ibrahim Bani. He is the prominent public health physician, currently serves as associate professor at the College of Medicine, Ajman University, and he's adjunct associate professor in chronic diseases epidemiology department, Yale School of Public Health, the United States. He's adjunct professor in the global health department at Rollins School of Public Health at Emory University, Atlanta, I believe, in the States, and his extensive national and international public health experience and works along with many organizations, including the WHO. He served in Saudi Arabia in the education, and he's so many published studies and on the journals. So welcome, Prof. Ibrahim Bani, and over to you.
Thank you, Dr. Zalal. I'm really pleased today to join this important webinar, including the regional partners. My comment concerning mainly about migrant health. I am currently a member of the task force for MENA region, and Sudan, one of the countries part of this, in which the need to develop a platform for migrant health. And here, why migrant health is matters for hepatitis B elimination, because see, most of these countries are destination for many of migrants, refugees, and also they are coming from countries with moderate to high incidence of hepatitis B. And in many countries, there is no policy for including these migrants into the health system, especially concerning hepatitis B, screening or vaccination or even treatment. On the other side, in the corner, if you take here in the region, in the Gulf region, I'm currently in the Gulf, in which hepatitis sometimes a test positive is lead to denial of visa or loss of work. So it's very important to work in the health policies for in the region, especially concerning hepatitis B to be included, that migrants should have the right for screening, as the right for also vaccination and treatment, because this sometimes lead to some sort of stigma, and many, they don't disclose if they have hepatitis. And this is why it's very important to have engagement of the migrants and engagement of the authorities also, whether work authorities or health authorities, to be engaged in the hepatitis. And this will have a great impact on the WHO target for 2030 of elimination. Here we have also, I am in Abu Dhabi right now. There is a global health disease elimination institute here, which also with partnership with US, and really they're working different, but I hope that hepatitis B should be targeted as this part in different countries, especially the Gulf and MENA region. So I hope Sudan, and also we have plans to have this platform also to be tested in Sudan with the Minister of Health. We already approached, and we haven't complete the process yet. But in other countries like Tunisia and Morocco, they already started testing this platform. Thank you so much, and really I enjoyed attending this important session. Thank you.
Thank you so much. It's our pleasure to have you among us, and thanks to all the pioneers and the mentors, professors who took their time to join us and support our small group work. Now I would like to welcome Professor Osman Khalafallah. He's a prominent figure, and sure, he's a well-recognized researcher. He's many topics published in major scientific journals. Shukran, Prof. Osman. Over to you. Professor Osman, you can unmute yourself. Okay.
Hear me?
Yes, we do. Thank you.
I'll start by saying this is really a very interesting webinar, really. And I myself, I am sure all the audience are very impressed by the expertise and the experience of our African fellows. Yani one really felt very much ashamed, very much ashamed. Yani we started medical education a long time ago in Sudan. We started the medical school started in 1924, and we had a lot of doctors. We had a lot of experience in epidemiology and general medicine, and we had a very good system of prevention of the communicable disease. But still we are far behind. I mean, studying and to know more about the prevalence of hepatitis B in Sudan here. Yani, I think we definitely, what we have mentioned, that we have to do more work. I mean, to fight something, you have to have more data about it. So far, I'm seeing the figures about the prevalence are very much little, really very much little. As a stigma, I mean, a lot of talk about the stigma, and I don't think really hepatitis B and C are stigma as HIV, because people, they don't know a lot about it. Yani a lot of people, yani anybody more or less know what is HIV. Like very few people who know about hepatitis B and hepatitis C and the problems and the complications of hepatitis B and hepatitis C. And this is what brings me to what we need to do about really giving in medical education, not only medical education, but in education in different sectors. I mean, Professor Al-Habbour, he mentioned the midwives. The midwife, generally, they are really the first contact possible in the villages with the primary health care. The medical assistant in the villages, even still we haven't got the dressing station, but we have got nurses and experienced nurses in the villages, and still they don't know very much about about hepatitis B and hepatitis C. So I think there is definitely a lack of information. Everybody knows about tuberculosis, we know about HIV, we know about malaria, we know about leishmania, and so on. But very little information about hepatitis B. So as Ali said, we need to add more about education in our curricula. We teach a little bit. I myself, I teach lectures on hepatitis, and I concentrate more on hepatitis A and E, and possibly B, very little about C. So we need really to inject more materials in our curricula in the medical schools, really. I am very much also impressed by what the Minister Heitham said, and the cooperation, I mean, with the different sector in the Minister of Health. I think we have to look really for more fund, and we have to collaborate with our African colleagues, and I'm sure that will give it a push, and we can fight hepatitis B and hepatitis C. And thank you very much. Thank you very much. Very interesting webinar, very informative, very informative.
Thank you, Prof. Osman, for your support. And thanks for all the mentors who shape our present and will shape our future. I'll move next to our next speaker, Dr. Mohammed Khair. He's a public health physician in the Kingdom of Saudi Arabia. Thank you so much for joining us today, and over to you.
Thank you. Thank you for this opportunity. First, I'm very, very proud to attend this very informative scientific meeting, and I heard the professors from different countries in Africa. Really, I do appreciate this, and thank you for invitation to attend this scientific meeting, and it is very informative. I would like to thank Dr. Abdelmonem Taib also, and organizers for inviting me. Really, I want to talk about the prevalence or the data which we are lacking in Sudan about viral hepatitis B. Yes, we have to conduct, I think we have to conduct surveys in order to know or to understand where we are and to know the burden and the magnitude of the problem itself. And then to have a strategic plan. I think the strategic plan should be for 10 years, because if we want to eliminate hepatitis B by 2030, I think this plan is for short time, for 5 years. I think if it is for 10 years, and we have to begin with the control. First, we have to control viral hepatitis B, and then we have to go to eliminate viral hepatitis B. Elimination and the strategic plan has there is many things we have to do. Integrated work we have to integrate. We have integrated work to do with in order to achieve our goal. I think elimination by 2030 is not real. We have to have a strategic plan for 10 years. And we have to learn also from the experiences from Uganda, from Rwanda, from other African countries, which they achieved their plans, and they achieved many objectives. We have to learn from them, and they have very nice experience. Really, we do appreciate this meeting, and I attended last week also a scientific session about hepatitis B and hepatic diseases. It is very nice, and we have to share the experience with and to collaborate with our colleagues in other regions in order to achieve our strategic plan. Thank you. Thank you for this opportunity. Thank you.
Thank you so much, Dr. Mohammed Khair, and these are very important remarks. We do listen and we do enjoy all the questions, comments, and remarks at the end of each session. We're not stopping. We'll continue to organize such sessions on weekly basis or fortnightly basis. Now I would like to give the mic to my colleague, partner in crime, Dr. Talba Ouda, Sarah Tayyib, to conclude this session. Over to you, Dr. Sarah.
Thank you so much, Zalal, my partner in crime. Of course, this day is really special for us in our humble platform to be able to be a part of this amazing panel of experts, international and national, and being able to host such an amazing webinar. Also, it's another special day because it marks one of the first steps toward the international elimination strategy for hepatitis B by the year 2030 for the elimination, and being here to witness the upcoming amazing changes in our national guidelines and all the great things that are going to happen, inshallah, after this webinar, and hearing the great news about the introduction of the vaccination at birth, the hepatitis B vaccination, that it will be introduced in Sudan by the mid of December. These are really amazing news. We are always humbled and privileged to be a part of this platform and being able to listen to our great mentors, professors, and the prestigious panel of experts. And also we were humbled today and privileged by having His Excellency Professor Heitham as an honor guest. So really we can not say much more than thank you very much for all our speakers today, our amazing panelists, and our extraordinary moderators as well. Thank you so much for our respectful audience as well, for your time and for your patience and for always supporting us and being part of this humble platform. Sudan is going through difficult times since the start of 2023, and we are still recovering. But of course, we are going to do our best to help Sudan recover, to thrive and survive, and to become better each and every day, inshallah. Thank you so much again for joining us today. It was really an amazing session, and we were really humbled and privileged by having all of you here next to us. And of course, this is not the end of our hepatitis month. We still have an upcoming lecture, inshallah, about hepatitis C. We did not forget about that. So be patient with us. And thank you so much again for joining us and for being part of our humble platform. We will leave our links for our social platforms as well in the chat box for you to join. Thank you so much and have a good night. وزي ما دايما بنقول فتناكم بعافية.
Thank you very much. Thank you very much.
لايك وشير عشان نوصل أكبر عدد من الناس وعشان تجيكم أخبار السيشنز الجاية. دي الروابط كلها، الفيديوهات قاعدة في يوتيوب وتليجرام لكل المحاضرات، بتنزل same day. فيسبوك بتنزل فيه الإعلانات والروابط للزوم meetings, LinkedIn for updates, and WhatsApp channel for updates regarding the hospital and academic activities. And of course, join our scientific community on WhatsApp. Now we've over 1,300 participants and would like to get more. You can copy and paste the links to your communities and share it with everyone. تصبحوا على خير، فتناكم عافية.